So usually it's a physiological self-limiting cause which will be transient, which will improve over that and it will be there. Otherwise, unilateral testes, we will see a lot of them who are persisting. That is non-endocrine usually. And then if you have a bilateral, you have to start thinking of a possibility whether there is any endocrine disorder from that regard. So we'll talk about testicular descent. It's basically an active process. For a testis coming down, if you have a scrotal testis, it means that it is a very, very effective and a functional testis. So it itself is an indicator of testicular function, which means that the testis is producing insulin-like factor 3, it is producing AMH, it is producing testosterone, and testosterone is working. So all of that, when this is there, then only you will say, okay, the testis will descend. So having a descended testis itself requires a lot of effort. From a pure mechanistic perspective, we can say that the testis is basically suspended via the cranial suspensory ligament from the diaphragm, and then it is attached to the lower part of the gubernaculum. So there is a disproportionate growth which is happening of the gubernaculum, which is attaching it to scrotum, as compared to the cranial suspensory ligament, which is mainly responsible as far as the overall testicular descent. But this process of, let's say, in a way, regression of the craniosuspensory ligament and the growth of gubernaculum is also dependent upon a lot of autocrine, paracrine, and endocrine factors in that perspective. So as time passes by, the CSL ligament will go down and the gubernaculum will enlarge, so testis will come down. Now, what are the three common organs which testis shares? So two more organs with which testis shares the embryological development. And what is their location and how do they develop? From the mesenchyme, from which ridge? So from the urogenital ridge, you will have the development which will basically happen in the perspective of the testis, the adrenals, and the kidneys. So what is the way they migrate then? The location. Kidney and adrenal so kidney mainly will be ascending up and testis goes down, and this is what becomes very, very important from that perspective, and this is how the testicular descent will happen. So now regulation of testicular descent can be classified broadly into two forms or two levels. One is at the abdominal phase, which is responsible for the descent of the testis from the abdomen till the around superficial inguinal ring. It starts very early. So if you look at the overall process, we discussed about how the testis develops. We talked about the urogenital ridge. We first had the testis appearing around 6 weeks of life. There's migration of germ cells happening around the same 5 to 6 weeks. Then you have the Sertoli cells which develop, which is around 6 to 8 weeks, which produce AMH. Then we have the Leydig cell which develops subsequently later from around 8 weeks to produce testosterone. So this is the whole process from that regards. So initial, it is mechanical, but a major factor which regulates the descent is the insulin-like growth factor 3, which is being produced via the Leydig cell under the influence of LH. So this INSL3 is largely responsible for migration of the testis from the abdomen to the superficial inguinal ring, and this happens by around 28 weeks of gestation. Now from there, the testis is now going to produce more hormones. It will produce testosterone, which is going to be converted via 5-alpha reductase into DHT, and also AMH from the Sertoli cell. And both of them, along with the local neurological control via the genitofemoral nerve, we have got the CGRP, which is calcitonin gene-related peptide, and all three of them play a role in the development of the inguinoscrotal phase, you can say, from that perspective. And here, you will have the canalicular phase of descent and the testis reaches up there, and from there will be the final descent. So now, Vibha, based upon understanding of these physiology, what will be the location of testis in various disorders of, let's say, impaired testosterone effect, which we discussed a couple of classes ago? No, it means everything. It means testosterone is not being produced. Yeah. Yes.
Not use any, like the Leydig cell will be impaired, so it will not produce insulin.
Yes.
So the testis will be abdominal.
So if you have an abdominal testis, it means it's more likely to be a complete testicular failure, even INSL3 is not being produced. That is more likely. Then subsequently,
then later on, if certainly is also impaired due to some reason, then AMH will not be produced.
So it may not necessarily cause a problem, but if you have a AMH production problem or a AMH resistance, why is the testis undescended?
AMH?
In AMH resistance or in AMH deficiency, often you will see you will get undescended testis. So what is the reason? So, but you have got so many INSL3s working. So abdominal phase AMH will not play much role.
Also, AMH is responsible for this.
No. But the abdominal phase is not AMH dependent.
Yes.
Yet you won't even have an inguinal gonad. Why? So if you have AMH resistance, yes, to descend, you need to have a clean passage. So as I was discussing on that, the first thing when you're making a new building is to destroy the previous ones. So suppose there is a fallopian tube lying there, suppose there is a uterine structure there, how will the test? The path will be obstructed. So even though AMH major role is in terms of the migration from the inguinal region, you will not even have an abdominal descent because of that. That is why many individuals who have a uterine development or a double system do have a undescended testis, which will happen in that regards. So as you said, if you have a complete gonadal dysgenesis, you will have an abdominal gonad. If you have a problem in AMH, a problem in testosterone production, a problem in testosterone action, you are more likely to have an inguinal position of the gonad which will be there. You will have an undescended testis. So if we now look at the patient who came to us with 17 beta HSD deficiency, what was the testicular location? So this is a typical one. So that means that there was enough. So if you now look at these things, you can make a diagnosis also. So you have a child who comes to you with atypical genitalia. There is micropenis, there is hypospadia. The testis, however, have come down. So what you can pretty much rule out is that a significant gonadal dysgenesis is unlikely. It's most likely that there is a testosterone biosynthetic defect or a impaired action. If you talk about that partial AIS also, he had a normal location. So which means that there is enough androgen which is there to leave at least here. So it means there will be some virilization which happens. So understanding of this makes a very, very important process. So by around 36 weeks, you will have the scrotal phase. So as we always say that if you are born prematurely, you will have less amount of calcium and therefore the risk of hypocalcemia is more. You will have less amount of glycogen storage. So you will have a risk of hypoglycemia. Same. If you're born before 36 weeks, of course, your prevalence of undescended testis will be high because many boys before 36 weeks would not have had descent. It does not mean that they have an abnormality. It's just that they were born early before the process should have taken place in that regard. That's why a preterm child has 3 times odds of having undescended testis as compared to a term child in that regards. So just to summarize again, so we have got the Leydig cells which are regulated between 8 to 12 weeks via the HCG and after that via LH through the LHCG receptor, and the Sertoli cells which are regulated via the FSH receptor. Now, as we discussed, you have got the LH acting on the LHCG receptor and FSH regulating the Sertoli cell function, and Leydig cell will then produce the insulin-like factor 3, which is the major regulator of the testicular descent, acting through its G protein coupled receptor, the LGR8. So problems in INSL3 and LGR8 will cause undescended testis, and you may have an abdominal testis even if everything else is normal. So it's not that if you have abdominal testis, that necessarily means that there's a gonadal dysgenesis. Even if insulin-like factor 3 is not there or it's not working, you will have the complete problem. So it's the major initial player, as to speak, as far as descent is concerned. Now, Leydig cell produces testosterone, which gets converted via 5-alpha reductase into dihydrotestosterone, acting on the androgen receptor, causing testicular descent. And we already discussed that HCG will take care of it in the 8 to 12 weeks. Now, we have discussed about this in much detail, that if you have a isolated hypogonadotropic hypogonadism like Kallmann syndrome, in which the LH is not there, you will have micropenis, but you will not have hypospadia because HCG is taking care of it. Now, do they have undescended testis or not? So they have micropenis, but can Kalaman syndrome people have undescended testis or not? If yes, why? If no, why? Why? So HCG is taking care of in the initial phase. No? And the INSL, the main factor is from 6 to 12. So they will have INSL3 through the HCG pathway. Because ultimately it's the Leydig cell which is being working on that. Yes, the other reason is that their testosterone levels will not go up beyond 12 weeks. So you will have levels which will be fine till your HCG is working. But once HCG goes down, your testo goes down. So that penile growth which happens and the testosterone dependent descent which happens will also be impaired. So Kalaman syndrome may have undescended testis as a cause which you need to understand. So that is because of the post second trimester deficiency of testosterone, so to speak, they will have a problem in that regards. Now, of course, AMH also plays a role in that, as does growth hormone and IGF-1. So we see a lot of growth hormone deficient individuals, they will have undescended testis, micropenis, and once you give them treatment, nothing else, you give them growth hormone, they will have a descended testis, which means growth hormone is also a player in terms of the testicular descent in that process. So this we have discussed already, that if you talk about the HPG axis, your LH starts to appear by around 14-15 weeks. Before that, there is no LH. The FSH comes even later. So all these roles happen a bit later, but testosterone is there much earlier, and that is largely because of the HCG which is mediating that. So if you have a LHCG receptor defect, will they have hypospadias?
So LHCG definitely, because LHCG will not work on the...
Yes. So if you have a complete LHCG receptor defect, you will have a complete feminine appearance. So basically what you are having is that your testis will be inside, there will be no descent at all, and they will have no testosterone production. Of course, you can have a variability of spectrum. So you may have some testosterone which is produced. So you may have variable one, but the most extreme form will be like a complete feminine appearance in that regards. So descent typically, as I said, it has got two phases, the abdominal and the canalicular scrotal, around 28-36 weeks. That is the time when your descent is happening. And that time, if your testosterone is low, because of whatever reason, you will again have an issue of descent in that regard. Now, why do you have this 1 year period? We say you wait till 1 year. Some people say 4 months, some people say 1 year. Why do you wait till 1 year?
4 months of age. 2/3 of the patients will...
Why? So why do they descend postnatally? That's the question.
During the period of puberty.
Yes. So there is a second chance that they get. The first chance was that maybe in the antenatal period, you did not have that much testosterone. Your mini puberty is going to raise your testosterone levels to be very high. They may go up to 200, 250, a normal adult male range. But is this testosterone as effective? So like if you talk about, if you give some younger child 200, 250, that sort of a testosterone, they will have many more changes. They will have much more penile enlargement. They will have hair growth as well and other things happening. But why don't these things happen too much in a child in the mini puberty? You don't see much pubic hair growth. You may occasionally see children who have some pubarchy. But why do, despite these high levels of testosterone, these infants not developing features of high levels of androgens?
Because the sensitivity of the androgen receptor is not proper. So
this is the way it has been developed. So if you think of it, mini puberty is basically there are so many speculations and other factors which are happening. Mini puberty is something in which we are recapitulating what has happened with our ancestors. So it is a process which used to happen, and in many of these animals, they don't have any mini puberty. They will be infant and then they will become pubertal and they will become fertile very quickly. But the human infant, if they become, that time you have onset of puberty, they will have too many difficulties. And that's why we talk about the phases of life, that this is more like brahmacharya, grahast and all those things. So human child needs much more longer period to develop, to grow and everything. So this is a reminiscent of what was happening in earlier animals. So that's why puberty happens. But body has developed mechanisms by which it is stopping that puberty to progress, because they do not want the child to become reproductive, active right now. They want to wait for 20 years or something till which all the knowledge and everything is gained. So there are many processes which happen. The most important, of course, is the central inhibitory pathways. So these central inhibitory pathways will come up and they will say, okay, LH, FSH should now be suppressed. So they will suppress the GnRH pulses. But meanwhile, all this high testosterone of 200, 250, which has been produced, will also be curtailed by the insensitivity. So what I'm trying to say is that even though the levels are very high, the body is relatively insensitive to this testosterone. It may cause descent, but it is not high enough, or it will not be potent enough or active enough to cause other virilization changes which are happening. But yes, definitely this postnatal descent is because of this postnatal surge. And this formed the basis of HCG treatment. If you give HCG to a child who is undescended testis, your testosterone levels will go up and you will cause a descent. But do you want to do that? Suppose you have an infant who comes to you with undescended testis. They want to go for medical treatment. Would you like to go ahead with HCG?
Wait for first week.
So you waited till 1 year, no response. Then they don't want to go for surgery. Would you recommend HCG?
Alone, the testosterone.
So if there is a hypo, absolutely we discuss in much more detail. For hypo, you should not use HCG because it will cause very high level of intratesticular testosterone, and in the absence of a protective Sertoli cell environment, it will cause damage to the germ cells. It is also true for the HCG treatment which was being given. So a lot of people, even during my training days, we used to give HCG as a treatment for descent of testis, and often they will be descent because it's not no wonders, because if you give HCG, your testosterone goes very high and you will have that. But this has been shown that even for testicular descent, giving this HCG may have deleterious effects. So there is no role of medical treatment unless you're thinking of a hypogonadotropic hypogonadism and you are combining it with FSH, because then your FSH will cause a Sertoli cell growth and then it will take care of it a bit, certainly from that perspective. So this is something which we need to understand. So as discussed, that there will be a chance. So if you look at the undescended testis, we are talking about at early gestation, you will have much higher prevalence of undescended testis. As your term increases, you approach term, the prevalence becomes less. So around 32 weeks, we are saying it becomes 10%, and at term, it's usually 3%. So anybody who is born early will be undescended testis. The chance will be very high, up to 30% as well. Now, after that, as Dhwani was talking about, there is a second chance. You've got the second process in which you can have a testicular descent, most commonly happening by 4 to 6 months, because this is the time when your peak mini puberty will be there. So in this time period, if somebody comes to you, do not rush, wait for some time. After that, and definitely, so if you see from here, there is a decline, but beyond that, the decline is very less. So some people say, okay, wait till 1 year. So it's like giving more chance. You say, suppose somebody is SGA and he's not catching up by 1 year, 6 months, 1 year, he'll theoretically not catch up. You know that most of them will not catch up, but still you want to wait for 2 years, 4 years. So now this figure of 1 year comes in. So why do you think, Dhwani, this figure of 1 year comes?
It was found that beyond 12 to 18 months, if we wait, then the further
yes,
chances of infertility and tumor.
Yes. So whenever you decide for a cutoff, there are two ways of looking at it. You say, okay, anybody who is below -2 standard deviation score, I will evaluate, because that means it's like 3% of the population. Or you can say that if your height is below -2 standard deviation score, there's a 40% chance of pathology. So same here, 4 months is an epidemiological cutoff, that, okay, if you want to see, realistically speaking, waiting between 4 months to 1 year, maybe few of them will respond. Maybe 20% will respond. They will have a spontaneous descent. But you may not cause damage. So the first principle is do no harm. So here your damage may not be there in the testis, but beyond 1 year, definitely damage will be there. So if you are between 4 months and 12 months, you are perfectly justified. in referring for surgery. But if you want to wait, even that is not a bad option. But beyond 1 year, probably there is no point, because one, the chances of recovery is absolutely less, and you will have a lot of complications in terms of fertility especially, which may happen in this perspective, which you need to worry. Now, if you have a preterm child, of course, if suppose somebody was born at 28 weeks, then you can't just say, okay, 4 months is there. You have to correct it for the gestation, and then you will have to give more time for them.